Now we are moving to our next speaker, Professor Dato Dr. Keng Hwang, to present on her topic, use of ultrasound in critically ill children.
Good afternoon to all of you. I would like to thank the first MHSC organizers for inviting me to give this talk. I'm a lecturer, a pediatric lecturer with the UniSHAMS, and I will be speaking on the use of ultrasound in critically ill children. Why do we talk about ultrasound? Because it is a safe, cheap, and portable, easily portable and available at the bedside anytime, anywhere, and there's no radiation. It provides a dynamic range, is reproducible, and it can be used repetitively to assess the progress of the condition, and we can also use it to guide procedures. The outline of my talk, I will be presenting on the 4 main domains where we can use ultrasound. First, ultrasound of the lung, ultrasound of the heart, ultrasound of the abdomen, and ultrasound of the brain. And I will illustrate with examples of cases that we may encounter in our working clinical life. So when you look at ultrasound lung, air is an enemy, water is a friend. Actually, ultrasound lung, because the lung is full of air, is thought to be not possible. But then we are using it to assess analysis of the artifacts that may occur. And we know that air and fluid interface, intermingle very closely. But we must also be aware that only acute disorders are in contact with the surface, and the deeper lesions may be missed. Most of the signs are dynamic. We can see it as it occurs. So we now talk about the features of the normal lung ultrasound. So if you look at the anatomy of the chest, we have the skin and soft tissue on this side, and the pectoralis muscle, the ribs in between, we have the intercostal muscles, and just below it is the pleura, and then the lung. So if you look at the sono anatomy of it, it is in gray, black, and a bit of white differentiation. And the rib, because the ultrasound waves cannot go through the rib, beyond it is dark and is a shadow artifact. And the pleural line is here, marked in yellow, and is we can see it moving. After I'll show you, is sliding. So in between are the intercostal muscles. Okay. So we are using artifact to help us analyze the situation. So the pleural line is here, and beyond the pleural line, you can see multiple lines, which are called A lines, which is a reverberation artifact, and it's equidistant from the skin to the pleural line, and it's all equidistant all the way to the lung tissue. Okay, and then here you can see the lung sliding. So the pleural line will move, and it's a thin line shimmering with there's not much of B line, it's all A lines, and the patient's lung is well aerated. So we can see this in a patient normal lung, or we can see in a patient with asthma or COPD. So what happens when the lung is not, when the pleural line is noted not to be moving? So you can see in this diagram,
breath, you have a breath and lung.
So you can see that the line hardly moves, right? So this is no lung sliding. So it means something, the lung is not sliding. So could this be a pneumothorax? So I would like to look for the lung point. So this lung sliding. So you can see the lung, the pleural line is sliding, and this part is not moving. And you can continue on. So this is sliding, and this hardly moving. So we have got the lung point, which is the intersection between the lung sliding and the lung that is not sliding. So what's the importance of this lung point? is specific for the presence of it is specific for pneumothorax. So you can see here the lung point is here. This is a patient who is on HFOV ventilation. So this part is sliding and this part is non-sliding, and this is where the pneumothorax is. So when you put the probe on the anterior chest, you can see this, right? And this is what the chest X-ray will look like, and you can see. So we are so used to seeing using chest X-ray to diagnose pneumothorax, but we need some learning to learn how to look for lung point. So what is a lung point? It's a place where the visceral pleura separates from the parietal pleura. It is the margin of the pneumothorax, and 100% specific if seen in the anterior lung fields in the presence of A-line. So the next normal sign that we look for is the curtain sign. Here we put the probe at the posterior axillary line, somewhere around the maybe 5th or 6th intercostal space, moving it up and down. And then you can see it's like a curtain of lung tissue moving to and fro. And here is the liver, here is the diaphragm, and here is the spine, the vertebra, and it ends at where the diaphragm is. So there's nothing beyond it. We need to make a note of this because it will help us in subsequent slides to look for, because basically when you look at this side, you are looking for pleural effusion. So the next slide will show you how the pleural effusion will look like. So this is the liver, the kidney, and this is the dark pleural effusion because it's water, fluid, it appears dark, and this is the lung which is consolidated or collapsed. And this is the vertebra extending, the spinal vertebra extending beyond the diaphragm. So this is called the spine sign. The presence of this spine sign will then tell you that what we have here is a pleural effusion. Okay, so the consolidated lung in the large pleural effusion appear like a jellyfish sign. So this is a jellyfish sign. And this is, you can see some turbidity in the fluid here, but it's not that, not a lot, but it tells you that this might be a bit purulent. And then you can see the spine here also. Okay, so this is another slide of the pleural effusion showing the spine sign. And here is the same thing, but now you can see the fluid there, you can see fibrin, you can see other kinds of tissue inside it, which suggests that this is empyema. Okay. So we now discuss a few cases. This is case scenario 1, which is a 5-year-old boy who had fever and cough for 1 week and respiratory distress on admission, and he required to be put on BiPAP. On auscultation of the lung, you hear decreased air entry, decreased chest expansion, and downward supercussion on the left side. And I did a chest X-ray, and looking at the chest X-ray, you decide that shall we put in a chest tube? Okay, and this is the chest X-ray, which show opacity involving the left hemithorax. So in those years before we use ultrasound, we tend to, okay, let's do a diagnostic test and see whether we get fluid. If we get fluid or pus, then this is where we put in a chest tube. And if there's nothing, then probably this is consolidation. But now with the advent of ultrasound, we can put a probe at the posterior axillary line there and moving up and down to look for whether we can see any fluid there. And here you can see that this is actually an empyema, and next to it is the lung, which is sort of collapsed. And you can see that there are multiple B lines, and the pleural line is also it's still moving, but it's a bit thick. Okay, so this is a patient that you can now put in the chest tube under ultrasound guidance. So those days when we do it blindly, that just poke the patient with the chest tube and then get the pus out, but now we do it under ultrasound guidance. So this is a purulent fluid that obtained, and this patient went on to improve. We put in urokinase and drain out quite a lot of the pus, and it got better. Okay, so now we have a second case scenario where we have a 3-year-old boy with low-grade fever, have been having low-grade fever for 2 days and coughing with associated shortness of breath. So a chest X-ray again showed almost the same thing with the hemithorax, the opacity involving the right hemithorax, and a slight shift of the mediastinum. The heart is being pushed to the left side. Okay, so if you have experience with the first one, you thought, oh, I will put in the chest drain for this one. However, the decision made was to do an ultrasound, and what do you see here? You see not fluid, okay? You see some structure inside here, which is the space occupying lesion. So you cannot, there's no spinal sign, there is there's no air bronchogram that you can see, just a structure here. So obviously this is a tumor. So a CT scan was ordered, and this came out as a teratoma, and alpha fetal protein was more than 10,000, and the treatment was a surgical excision of the teratoma. So an ultrasound did help make a lot of difference, in the sense that you will not blindly put in a chest tube. Okay, so now we come to what are the signs that you can see in consolidation, because consolidation also come out with opacity in the lung. Okay, so you will see, because it's all consolidated, the lung appear red, you will see B lines, which I did not describe much about, but there is also subpleural consolidation and some Schreck sign, tissue-like sign or hepatization, and a dynamic air bronchogram and a lung pulse. So we will see some slides on this. So here you can see this is a longitudinal view of the chest, and you can see multiple ribs here, and you can see some pleural line. And at the pleural line, you can see that it's like a consolidation with the tissue being torn off. So this is called the Schreck sign, right? Subpleural. Usually in a normal patient aerated lung, you will just see a single thin pleural line sliding. So, and these big lines that are coming downwards from that pleural line, this one, they are all coalesced B lines, so presenting as broad B lines. Okay, so this is a slide of ultrasound of the patient being kept in the prone position. This is the chest wall, and here is a big sort of collapsed structure with some pleural effusion. What is black is always pleural fluid, and here you can see within this structure, you can see air bronchogram, which gives it a starry eye appearance. So it can either be dynamic or is it static. So some of it, this part looks static, but you want to see dynamic, is better seen in this. So this is the patient who is supine, and we put the probe at the posterior axillary line there, and you can see that the lines are moving. So a dynamic air bronchogram suggests that this could be a bacterial infection, and this is actually the rib shadow. Okay, so not much of fluid. So this is a consolidated lung. Okay, so the consolidated lung in pneumonia, you probably did a chest X-ray, and you will see some areas of opacity here, and then here you will see the Schreck sign. This patient is also on high frequency ventilation, and here is the hepatization, where you can see the starry sky appearance of the air bronchogram. So ultrasound in a way helps to confirm that this is consolidation, or is it fluid, or is it a tumor, and we can use it to assess the response to your antibiotic therapy. So in this patient, you wouldn't put in a chest tube because this is consolidation. Okay, so we have there are more to ultrasound lung than what I've shown you, but I think it's enough to tell you what's the importance of being able to do ultrasound lung in the conditions that we mentioned. So now we go on to ultrasound the heart, which is we will mainly concentrate on the presentation in the first week of life. So here we have a baby boy who was discharged home at 6 hours of age. He was the second child in the family. Mother's pregnancy was uneventful, and he was feeding well. However, when he was 2 days old, he was found to be very deeply cyanosed and tachypneic. And he was brought to the casualty, and on examination, the pulses were poorly felt, but no murmurs were heard. So you have at your disposal an echo machine because you have suspected some, hopefully some doctor-dependent heart lesion. And this is what you see when you put in did the echo. This is a 5-chamber view. So you have a large left atrium, right atrium, tricuspid valve, and the right ventricle is quite small and trabeculated. And the right ventricle outlet is the pulmonary trunk, right? And it divides into two. So you can see two main vessels here where it divides. But at the opening of the pulmonary valve, you hardly see open, right? It doesn't flip open. So there is a little hole here. So this is critical pulmonary stenosis. So critical pulmonary stenosis patient will become sinus, and when you measure the pressure gradient, it will be like 60 to 70 millimeters of mercury. Normally it's around 10 to 15. So this is really severe obstruction to the right ventricular outflow tract. So we start the patient on IV prostaglandin. Of course, this patient would have been intubated and ventilated, and the saturation did not come up. So you start IV prostaglandin, and immediately you see the patient becoming pink. The SpO2 goes up to 80, 85, right? And this is the PDA that is being opened up by the prostaglandin. And so it's a life-saving procedure in this patient with critical pulmonary stenosis, where you then send the patient, stabilize and send the patient for a valvotomy. Okay, case scenario 4 is a 5-day-old baby who was discharged home after 24 hours. You see, all our well babies, we tend to send them home early, and then is then found collapsed and rushed to the hospital. He was pale with gray lips. The right brachial pulse could just be felt. The femoral pulse were impalpable, and his liver was significantly enlarged. So he's actually gone into some form of heart failure. Blood gases showed severe metabolic acidosis. Okay, so what is your differential diagnosis? I think we would have put in sepsis, inborn error of metabolism, and maybe this is a doctor-dependent heart lesion. So an echo was done, and this is the echo probe being put at the suprasternal notch, where you can see the arch of aorta as a curve down here, right? And here you can see that there is a narrowing, right, with a very small opening. Very small opening. You can see that the pressure gradient here is very high. So this patient came in collapsed because there is no cardiac output. The cardiac output is very markedly reduced. Though there's enough flow to the brain, to the both upper limbs, to the subclavian artery, but hardly any flow to the descending aorta into the abdomen and the lower limbs. So the kidney will be the first to suffer ischemia. So immediately we start the patient on IV prostaglandin, and now we have duct open up, we reverse flow to supply the aorta and the flow to the abdomen and the lower limbs. So this is very important because if you are delayed in picking up the diagnosis and the patient became ischemic for quite some time, then the kidney will suffer. And actually, in that sense, when the kidney goes into failure and not reversible, then doing the operation makes no point because it will go into renal failure. So early detection makes a lot of difference, and starting the IV prostaglandin. So now I've shown you two cases, one, the critical pulmonary stenosis, and then one on the aorta left side, the severe coarctation, where the ultrasound make a difference. Now we have another case where you have a baby born to a mother with diabetes. Mother was quite well controlled. And you was doing your postnatal rounds with your SpO2 monitor, and you picked up the patient having a low SpO2 of 85%. This the pre-doctor and post-doctor that we will talk about in subsequent, if you attend subsequent lectures. And then you will see that there's a soft systolic murmur was heard, and he was admitted because he was not very pink. So what's your next step? Of course, you have in your ward somebody who can do an echo. And then you see, very unusual, I hope you can remember this picture, two vessels parallel to each other, right? So when we look at vessel, we cannot just say this must be the aorta, this must be the pulmonary artery. We have to follow it. So this aorta also is actually going downwards, and this is actually going this way, and the normally it would have done this, it would have gone upwards, and the pulmonary artery will go downwards. But these two are parallel to each other. Okay, so make you suspect that this could be a TGA, transposition of great vessel. Transposition of great vessel is parallel circulation, right? So you can see the blood returning, superior vena cava, inferior vena cava, right atrium, right ventricle. It goes into this big vessel, which is the aorta. So the aorta now is receiving the oxygenated blood. And the blood in the lung, which is pink, is coming back to the left atrium, left ventricle, and going up into this vessel that branches, which is a pulmonary artery, and going back to the lung again. So how can this patient survive? It survive in utero because the placenta is the one providing the oxygenation, but it need to survive because of the PDA and the AST. Okay, so if this PDA close, which eventually all our PDA will close within a week of life. So if this PDA close, the patient will become sinus. So what must we do? So anyway, this is to just show you the diagram, but this is the echo of the heart. It is a big, we already show you the parallel vessel, and then when you do the suprasternal area, you see two vessels. Instead of the arch of the aorta and the pulmonary artery, we see two vessels on top of each other. And this is a sign to tell you that this is a TGA, right? And then when you do your 4-chamber view, you can see one vessel. This is a right atrium, right ventricle. Coming out from the right ventricle, you see one blood vessel, which has no branches, right? And this is actually the aorta. So aorta is coming out from the right ventricle. The next slide will show you the 4-chamber view with this is the left, right atrium, right ventricle, left atrium here, and left ventricle. And what is the vessel that is coming out of this left ventricle, which normally is the aorta, is now the pulmonary artery, which divides into two. So now you are convinced that this patient has a transposition of great vessel and their parallel vessel, and so the PDA is closing. So you need to open up the PDA. So this patient has a small ASD, but it's restricted, so it won't be alone. It will not provide enough mixing for the patient to get oxygenation. So we need to open up the PDA. So having opened up the PDA, refer him to stabilize the patient. So open up PDA means you give IV prostaglandin, then you send this patient to the cardiac center where they can do an atrial septostomy, and about 2 weeks later, this patient will undergo a switch operation. So that finishes the echo of the heart. And why the echo of the heart is so important is because our patients do collapse during the first week or so of life, because they are doctor dependent. The PDA will close around this time, so they close very early, or may take 1 week to close. So when you close, the patient will be in shock, and you need an echo, and starting IV prostaglandin is life-saving. So now we have a case scenario 6, which is ultrasound, which I want to demonstrate the use of ultrasound abdomen. So ultrasound abdomen can be used to diagnose things like intussusception, appendicitis, but we will not go into it. We will just talk about this case, which we now see quite often, which is dengue fever. This patient is 10 years old, had fever for 3 days, and the NS1 was positive. So he's being diagnosed as having dengue fever. So he came to the clinic and was found to be hypotensive, in shock, and it was given 20 ml of fluid. So, you know, dengue has got febrile phase, critical phase, and the recovery phase, right? So which phase is the patient in? So this is a day 4, a dengue illness. Temperature just became a febrile, but hematocrit is going up 42 and platelet is 24,000. So when you did the ultrasound of the abdomen, we found that this is a gallbladder and the wall looked thickened. So it looks like it is about 1.08 centimeters. Normally should be about 0.5. Okay. So you can see this is the liver, this is the kidney, this is the fluid between the liver and the kidney, which is called the Morrison's pouch, right? And there's some pleural fluid also. So there's ascites and pleural effusion. Okay, there's ascites. So this patient was managed according to the protocol of managing dengue fever, warning sign and leaking fluid. So he was given his fluid according to the regime. And subsequently on day 7, this we are usually leaking around 24 hours, hematocrit has come down to 32.5 and platelet has gone up to 82,000. right? And when you did the ultrasound of the gallbladder again, you notice that the wall has become thinner. Before that was quite thick. So, and there's not much of ascitic fluid. So patient has improved. So this is how we can use ultrasound of the gallbladder to help us in our decision making on dengue management, because sometimes we realize that it's a bit difficult to decide, is this patient in the critical phase, the leaking fluid that we need to give more fluid, or is it not yet leaking and we just need to just maintenance fluid? So able to do ultrasound of the gallbladder will be useful. Okay, so now we come to the fourth domain that I want to talk about, which is ultrasound brain. Ultrasound brain is regularly used by people working in the NICU, right? They usually use this acoustic window, which is anterior fontanelle, posterior fontanelle. I think many people are not aware that there are so many fontanelles that we can actually go into. So anterior fontanelle is usually in the neonatal period. Occasionally may use a posterior fontanelle, but I here want to put stress on the temporal window and the mastoid for fontanelle. The temporal window is to look at the base of the brain, temporal lobe, horn, midbrain, third ventricle, and circle of Willis. And why you want to look at the circle of Willis is to measure the flow. So here is the base of the brain. The circle of Willis is here. You can see the mid-cerebral artery and the posterior cerebral artery. And you can actually look around. Actually, this patient had a bit of subdural effusion too. But we want to measure you put your pulse Doppler over the mid-cerebral artery, and then you put the pulse Doppler, and then you start your measurement, and this is what you'll find. That the pulsatility index is you can measure the pulsatility index and you can measure the resistance index. The pulsatility index is actually taking the peak, the systolic flow minus the diastolic flow. So this is systolic flow, this is diastolic flow, and divide by the mean. So you get your PI. For resistive index, we take the systolic flow minus the diastolic, peak systolic, diastolic measurement, and divide by the systolic velocity. So in that way, you get your resistance index. These are measurement of flow resistance. Okay, and the value usually will be around like this. Ri is 0.7 and Pi is 1.32. This is a normal brain. The pressure is not high. So we are going to use this to help us in another case I'm going to discuss to assess the transcranial, the intracranial pressure. Okay, so now we have a 1-month-old child who was diagnosed with group B strep sepsis. He was given a week of antibiotics and supposedly to be well for discharge, but developed septic shock and then developed a seizure. Okay, and lumbar puncture was done, which confirmed meningitis, and so the antibiotics were increased, the dose was increased. However, after 2 weeks of treatment, he again developed a focal seizure with a new neurological abnormality with some focal sign. So ultrasound with a linear probe was done. This to look for thrombosis. So you can see the superior sagittal. So this is a linear probe. There are many probes that you can use in ultrasound. So you need to roughly know the probes to use. So this linear probe was put on the anterior fontanelle, and we can see that in where the superior sagittal sinus is, there is a clot formation and a density here, right? And when you put the color on, you notice that the flow is a bit interrupted. You just see the clot there. And when you put it at the sagittal view, you can see the sagittal sinus being outlined. You can see that there is a thrombus formation, right? So this patient was started on anticoagulation therapy in addition to the antibiotics. And I think you can see that this is getting better now. So the clot light is resolved. And if you compare this with the previous one, it looked quite clear. So this ultrasound done at the bedside allow us to make a quick diagnosis of the patient having a thrombosis of the superior sagittal sinus, and then we can start the anticoagulation therapy and also optimize the antibiotics. Okay, so in case scenario 8, where I'm going to talk about the use of the resistant PI and the resistive index to assess the intracranial pressure. So this is an 8-year-old girl who had a fall 2 months ago. She was well before this. Then developed sudden onset of headache, and a drop in her GCS. So she was intubated in the emergency department. So the thinking at this point was, is this, did she had a bleed earlier on, and slowly the blood was accumulating, and then now she has got raised intracranial pressure, and then she's coma. So an urgent CT scan brain was done. So when you look at this brain, you can see a lesion forming in the temporal region. And then the ventricle is so slit-like, you cannot really see it being compressed. And there's not much gyri, gray-white differentiation is not good. And the midline is also shifted. So these are all the signs of cerebral edema. So this patient undergo a urgent cranectomy. So after that, he was ventilated in the high-speed ICU and was on close monitoring on cerebral CVP monitoring as well. So anyway, the diagnosis made was that this could be a right middle cerebral AV malformation with acute bleed, but the ICP is very high after the operation, so we need to stabilize this patient, did cerebral resuscitation, give 3% normal saline to reduce the edema. And the ICP is a bit highish, around 25, but it was reasonable because normally it should be lower than 20, but 25 appeared to be okay because the blood flow, when you put him on the doing this view, looking at the middle cerebral artery and measuring it, you find that the flow is quite okay, satisfactory, despite the raised ICP of 25. Okay, so the cerebral blood flow still adequate despite ICP of 25. So the decision was to accept this high ICP. But you notice that on the people on the right side was fixed and dilated, and people on the left side was 4 millimeters reactive. So there's another place where we can actually look at, use the ultrasound. You put it over the orbit, and you can actually see the optic nerve. So the optic nerve here is protruding into the orbit. So this is also a sign of raised intracranial pressure. And then you can measure the optic nerve sheath diameter. So the optic nerve sheath diameter is measured about 0.3 centimeters from his optic disc, and it's around 0.493, which is a little bit raised because normally it should be 0.44. But we actually don't know the value for children. This is the value for adults. Unfortunately, the EVD got dislodged because during the manipulation. So now there is no actual monitoring of the ICP, right? And the craniotomy site was still full. And this was on day 3 of admission. So what to do? Pupils were still fixed and dilated on the left side. Craniotomy site was still tense, right? And measurement of the eyes using the middle cerebral artery measurement, the pulse Doppler on the middle, you can see that the flow is not very good, and there's now reverse flow. So reversal of flow suggestive of a very high ICP. So what to do? So the measurement, you can see compared with what was before, 0.7, and this is 3. They're higher than what was previously noted, right? So it's 1 and 3, which is, we want it to be below 1. Here also below 1. So we need to do something. So using this to guide us what to do next. So the subsequent management without ICP monitoring was to use the ultrasound Doppler measurement, the RI and the PI, and use inotrope to raise the MAP to around 90 millimeters of mercury. So they did serial ultrasound measurements and using inotropes to see whether we can put the MAP around 90. 3% saline was given as well. And you have to measure the electrolytes. If it becomes hypernatremic, you have to cut down, stop the 3% saline, and also thiopentone for sedation and burst suppression. So on the second day of the post-cerebral resuscitation, the MAP was around 92. And this is, I think the flow, it seems to be not too bad. There's a lot, I mean, looking at the color is a lot of rate moving to along the middle cerebral artery. Okay, and so the measurement at the pulse Doppler showed that the RI is around 0.62, which is good. We want it below 1, and the PI is around 1.05. Before that, during the time when he had raised intracranial pressure, it was around 3. So then it was, the MAP was maintained at around 92 with inotropic support. So repeat CT. So the repeat CT showed much improvement. You see now the ventricles are being easier seen, and the midline is more central, and the gray-white differentiation is better. So the patient went in for excision of the AV malformation and has since been discharged and undergoing rehabilitation. So we have discussed how ultrasound can be used in certain conditions in the lung, especially important in the first week of life for doctor-dependent cognition, because we need to decide on giving the prostaglandin, and again in the management of dengue, and ultrasound of the brain as well. But don't forget, it is operator dependent, and we need to be trained. You cannot replace the radiologist, right? So, but it would make a difference in critical situation where decision making is needed immediately, because our patient cannot be moved to do the CT scan. So having a portable ultrasound machine at the bedside will make a lot of difference. So if you want to learn more about ultrasound, then you probably have to attend a course where all this will be taught at the course with some practical experience as well. So thank you for your attention, and I'll be glad to answer any questions you have about the use of ultrasound in critically ill patients.
Thank you, Dato Teh. So if anyone have any question, okay, there's one question.
No question.
Any question? No, that's not a question. Any question for any other participants for Dato Teh? Okay, so we have one question from Shafiq. Dato, okay. In critical phase of dengue case, when deciding to give fluid, is it necessary to rely on hematocrit and clinical sign to monitor the plasma leakage?
I think in the critical phase, when they are leaking fluid, we will be monitoring the hematocrit and the platelet. So we will be looking at the hematocrit, and it's going up, say 40-something%, then we would give fluids. And there is a regime to follow. WHO has given us some guidelines, so how much to give. So if the patient coming in shock, we would have given a bolus. Then we'll reassess, and then we think that is leaking, then we will give him like 7 mL per kg per hour for a few hours, and then reassess. So you have to be doing your hematocrit and your platelet very regularly during this critical phase. But I just put in the ultrasound of gallbladder as something to help us, because by looking at the edema that has occurred, it will tell us that this patient is leaking. Does that answer the question? So we need the hematocrit, definitely.
Okay. All right. Thank you so much, Dato. Is there any more question? Okay, I think that conclude our session today for the morning session.